Hello everyone, my name is Jonathan Finnoff. I'm the Chief Medical Officer for the U.S. Olympic and Paralympic Committee, and I'm a professor in the Department of Physical Medicine and Rehabilitation at the Mayo Clinic. I'm going to be talking to you today about ultrasound-guided surgical procedures. I receive royalties from UpToDate and Demos Publishing, but neither of those have anything to do with the current presentation. Upon completion of this presentation, you should be able to outline the 3 generations of ultrasound-guided procedures, describe the rationale for ultrasound-guided surgical procedures, and how to perform an ultrasound-guided fasciotomy. Ultrasound-guided procedures have gone through a series of evolutionary steps. The first one being the first generation procedures, where essentially you just used ultrasound to perform a procedure that you would normally not use any type of imaging, such as a peritendinous injection, intratendinous injection, knee injection, and so on. Then they evolved to second generation procedures, and these are procedures that really required some type of image guidance to be able to perform them safely and effectively, but they weren't used with any specialized tools. So this would be a perineural hydrodissection or an aspiration and lavage of intratendinous calcifications. Third generation procedures use specially designed tools for the actual procedure. So this might be something like a sonographic debridement, which I'll talk about during this presentation, or using a hook knife to perform a trigger finger release. So this is just following in the footsteps of established medical procedures and the evolution of medicine. So it used to be that when you had a heart attack and coronary artery disease, they would do a coronary artery bypass graft, but then they were able to start doing it with angioplasty and stents, and this has been done in numerous other fields. So why not just continue doing traditional surgeries? Well, there are certainly advantages to ultrasound-guided procedures, including it reduces the cost. So essentially you can perform these in an outpatient setting. You don't have to use as much equipment, you don't have as much personnel, and so it saves overall costs to the healthcare system and the patient. And there are less complications because you see where you're going to be cutting and then you perform the cut. You also have a quicker recovery following the procedure because it's less invasive, and therefore you have increased patient satisfaction. Doesn't hurt as much, doesn't cost as much, you recover quicker. That makes people happy. But it's not perfect. Sometimes you can't see the structures you want to be working with, and therefore you have to abort the procedure. There are also a few different procedures that have been developed and studied, but there haven't been a lot, and so it's still very much in its infancy, and we can only do a limited number of procedures, but that'll change over time. We also need to figure out who's going to be taking care of the complications. Now, this is similar to the same thing with angioplasty. A cardiologist, an interventional cardiologist, is going to do an angioplasty, but it is the cardiothoracic surgeon who takes care of a complication if something goes wrong. And the same thing will hold true with these types of procedures. And there aren't very many people who are doing these procedures at this point, so we need to figure out how to train people adequately to do them safely and effectively, and there probably should be some type of certification process. And, you know, if you're doing a new procedure, sometimes people feel like you're getting on their turf, and so there are always politics that you have to work through when you're introducing new procedures into your practice. So now we're going to talk about specific cases and research. So the first case I'm going to present is of a 47-year-old right-hand dominant individual who had some triggering of their third digit. They tried conservative measures, including splinting, a corticosteroid injection, and activity modification without any benefit, and they opted for an ultrasound-guided surgical trigger release of this, trigger finger release of this triggering tendon, which you can see here on the right. So the way that we do this is using an 18-gauge spinal needle that has been modified into a cutting device. This was developed by Hopkins in a porcine cadaveric model, where you take the stylet out of the 18-gauge needle, cut a little notch in the hub, and then insert the stylet in an opposite orientation to its normal orientation, and that creates a V-shaped cutting tip. Here you can see a notch being cut in the hub of the needle. And here you can see the stylet having been inserted into the needle upside down, so it creates the cutting tip. And here is an ultrasound picture of a cutting tip spinal needle cutting through an A1 pulley to release the tendon such that you have no more triggering. Immediately following the procedure, the patient should have relief of triggering because you've cut through the tissue that was causing the triggering. They need to take it relatively easy for a week, but they can do normal daily activities, just no repetitive gripping types of things, no heavy lifting, and then they can resume normal activities after approximately a week. There have been a number of different procedures described using ultrasound in order to release a trigger finger. Some have used hook knives. There have also been ones where they used modified needles, and of course there have been ones with cutting thread, all of which seem to be very successful. The next patient was a 38-year-old right-handed female emergency medicine physician who was an avid cyclist, and she had hand paresthesias and pain that were eventually diagnosed as moderately severe carpal tunnel syndrome. The patient underwent standard non-operative measures and wasn't getting better, and so was debating between a standard surgical release and an ultrasound-guided release, and opted for the ultrasound-guided release. Here's a video demonstrating the Sonex SX1 microknife, which has some balloons, and you can see the knife being activated there, and that can be deployed to cut the transverse carpal ligament. Here's a video that will demonstrate this for you. So there's the transverse carpal ligament, the median nerve, ulnar artery. So here is inserting that Sonex microknife underneath the transverse carpal ligament between the median nerve and the ulnar artery. Inflate the balloons to move the neurovascular structures away from the microknife. And then you activate the knife, and the knife is then retracted and pulled through the transverse carpal ligament as depicted in this video. So here's a picture of the microknife. Here's a cadaveric hand. And then this is looking at an ultrasound picture of the transverse carpal ligament with the hook of the hamate, which is where your ulnar artery will be, and your median nerve is right in this area. And then you're identifying this safe zone. Then you make a small incision and insert the microknife. The microknife is then advanced underneath the transverse carpal ligament until it is at the tip of the transverse carpal ligament. So here in the lower right is transverse carpal ligament, and there's the tip of that microknife. And you activate the balloons, which push the median nerve and the ulnar artery away from the microknife. Then you activate the microknife so it pops up, and then you retract it through the transverse carpal ligament. Here's an ultrasound image showing that the microknife has cut this area. Here is the cut. And so now we're mobilizing it, and you can see how the transverse carpal ligament is transected. And here is the image in a cadaveric model after it's been resected or dissected. And then this is just a axial image, or I guess an axial cut through that area, demonstrating the image of that transverse carpal ligament being transected. And that is the incision, so it's very small. You can just put a Band-Aid over it. This has been studied in more than 1,000 in more than 1,000 individuals at this point, and multiple different physicians from different specialties: orthopedics, plastics, sports medicine, physical medicine, rehabilitation, radiologists have done this procedure. On average, it takes between 8 and 15 minutes, and the patient is allowed to resume normal activities as tolerated thereafter. And to date, there haven't been any significant complications reported with this procedure. Another way of doing this procedure is using an ultrasound-guided cutting wire, cutting thread to perform the procedure. So you would first start by scanning the area and identifying the exact same structures that we talked about previously. Then you insert a needle, and in this case it's typically a TUI needle. It's a blunt-tipped needle to reduce the risk of skewering something you don't want to. You guide it underneath the transverse carpal ligament. Then you thread the cutting thread through the needle, and then you pull the needle out, and it leaves the cutting thread deep to that transverse carpal ligament. Then you reinsert the needle, but this time instead of going under the transverse carpal ligament, you go over the top of it, and you go out the same hole on the other side. And then you thread the thread back through that needle. So now the thread is looped around the transverse carpal ligament, with part of it deep to the transverse carpal ligament and some of it superficial to it. Typically, when I'm using the cutting thread, I'll put syringes. I'll insert the end of the thread onto some syringes and then put some caps on the syringes, and I use the syringes as a handle in order to pull the pull the thread through that transverse carpal ligament and cut the ligament. So there have been several studies on this as well. You have just 2 small needle holes. People recover very quickly afterwards, and there appear to be very rare complications associated with it. So here is an ultrasound image of the transverse carpal ligament surrounded by that cutting thread. And here is an image of the cutting thread being scissored or pulled through that transverse carpal ligament. So that's what the ER doc opted for, and she was able to actually go and work her ER shift immediately following that procedure. She was able to resume all of her normal activities within 1 week of the procedure, and at 1 year follow-up, she was still symptom-free. The next case is of a 19-year-old female collegiate soccer player. So she had a 3-year history of bilateral anterolateral leg pain. It was an aching, burning pressure pain that would get up to 10 out of 10 in severity when she would run aggressively, and when she would rest, it would go away. When it was present, she would feel some numbness, tingling, and weakness, but when the pain was absent, she didn't feel those symptoms. Treatments so far had included activity modification, physical therapy. She'd tried heat and ice and anti-inflammatories, all sorts of stuff, and nothing was working. She didn't have any significant past medical or surgical history. On physical examination, she was an athletic individual with a normal gait pattern, and she had a normal examination with normal peripheral pulses, normal neurologic examination. She wasn't tender. So this could be a whole bunch of different things: bone, muscle, peripheral nerve, could be an infection, vascular, chronic exertional compartment syndrome, or referred pain. These are all the different things that can cause leg pain. However, in this particular case, and neoplasm. In this particular case, it was chronic exertional compartment syndrome. So chronic exertional compartment syndrome is often bilateral. It doesn't have any gender predilection and is more common in the anterior, followed by the deep posterior, then the lateral and superficial posterior compartments. And I'll talk about those in a second. Frequently, it occurs in conjunction with other diagnoses. So don't forget medial tibial stress syndrome, popliteal artery entrapment, and so on. This is caused by excessive increased intracompartmental pressure during exercise, and that results in decreased intramuscular blood flow and oxygenation. So here are the different compartments of the leg. There's the anterior compartment. Remember, that was the most commonly affected. Lateral, superficial, posterior, which has your gastroc and soleus complex, and then your deep posterior compartments. And you can see that there are neurovascular structures in each of these compartments. And so when you have an increase in the intracompartmental pressure, it starts to squeeze on those neurovascular components, and people will often have paresthesias and weakness in the distribution of the nerve. So the history is usually of a cramping, burning, aching tightness that is that begins at a specific intensity and duration of activity, and then when you stop that activity, it goes away. People can't push through this. It just gets worse and worse and worse until it essentially shuts you down. They may report weakness and paresthesias, as I talked about before, and those will be in the distribution of the relevant nerve. But on physical examination, it's usually normal. But if you have them exercise, you might find that they have some swelling, tenderness. Frankly, they may even have some neurologic deficits. So to diagnose this, the most common tool or study is a pre- and post-exercise compartment pressure test with an intracompartmental pressure monitor like the one shown in this picture. And there is a criteria that was established by Pedowitz where you should have a resting intracompartmental pressure of less than 15 and a 1 and 5 minute post-exercise compartment pressure of less than 30 and 20 respectively. If you're above those levels, then that is highly suggestive of chronic exertional compartment syndrome. So there are a lot of different treatments. One is just modifying your running technique. So if you have anterior compartment chronic exertional compartment syndrome, if you switch from a heel striker to a mid to forefoot striker, then you reduce the stress on your anterior compartments, and therefore you stop having anterior compartment chronic exertional compartment syndrome, but it doesn't help with lateral or posterior compartment syndrome. You can also do Botox injections or botulinum toxin A injections, and there have been several studies on this that have shown good relief. But it does cause some weakness, so it can decrease performance, and it may also destabilize the ankle and predispose to injury. So while it works and it's relatively non-invasive, it's not long-term because botulinum toxin is reversible, and it can cause some other potential problems. The most common treatment for this is a standard surgical fasciotomy, but it takes a long time to recover from this, and the success rates are variable, with complications being reported in up to 16% of cases. I did a study a number of years ago that used ultrasound guidance to fenestrate the fascia that was lining the compartment. And the first patient I did this in was an 18-year-old collegiate lacrosse player with a prolonged history of anterior leg pain that was diagnosed as chronic exertional compartment syndrome. We talked about various treatments, and she decided to go with this ultrasound-guided percutaneous needle fenestration. So you essentially map out where are the nerves, where are the compartments, and determine what the most optimal needle path is. Now I put marks on here because the needle I used was a 3.5-inch needle, And so I marked every 3 inches, and I anesthetized between each of these marks to try to minimize the pain associated with the procedure. I use sterile technique with this. I alternate between the anatomic sagittal and coronal planes to look at the needle and where it is in relation to the fascia. And I advance from a proximal to distal direction. I use a local anesthetic, lidocaine, for local anesthetic. And typically when I'm doing the local anesthesia, I'm using a 25 or 22 gauge 3.5 inch spinal needle. Then I will repetitively fenestrate the fascia with an 18 gauge 3.5 inch spinal needle. So I do think that using that Hopkins technique I described previously, where you do a notch in the hub and flip the stylet so that you have a cutting tip, is probably a really good way of doing this if you're going to go with the fenestration, because it's going to be more of a cutting procedure as opposed to just a perforating procedure. But here is local anesthetic being placed over the top of the fascia. Here is the needle going back and forth and cutting the fascia. And here's a short axis view of the same thing. Here is a picture of me performing this on an athlete, and that's the fenestration motion. After the procedure, I have people take it relatively easy for about a week, but I let them begin normal activities as far as activities of daily living almost immediately afterwards, and then resume full unrestricted activities 1 week following the procedure. And in the case of this athlete, she was able to resume collegiate lacrosse within a week. So you think about that, if she had had a fasciotomy, then only about 80% of the time it works, 16% complication rate, and she's looking at an 8 to 12 week recovery. So with this, it was just a shot or a needle fenestration, and she got back to full unrestricted activity after a week. I followed her up for a 1.5 years, and she had no resumption of symptoms. So I think this is interesting, but it's only one case study, so it's level 5 evidence. And I worry about the fact that because it's just a needle fenestration, maybe it will, the fascia will heal and they'll have a resumption of their symptoms. So it's really hard to say how effective this will be in large case series or randomized controlled trials. So thinking about that, I decided it would be a really good idea to try to develop a technique where we're actually cutting the fascia instead of fenestrating it. And we developed this technique and proved it in a cadaveric model with a study led by Dr. Leaders. And essentially we took 10 unembalmed knee, ankle, foot specimens, and myself and another physician did ultrasound-guided fasciotomies on each of these specimens. So we each did 10 compartments. And it was very successful. The next procedure was, or the next study was a case study on an individual where we were translating it from the cadaveric model into an actual person, and this was a 41-year-old female with a 5-month history of exertional right leg pain, and she was diagnosed eventually with anterior compartment syndrome. And so we talked about an ultrasound-guided fasciotomy, and she opted for that. She was able to return to unrestricted activities of daily living within a week and was able to run without pain or any limitations by 2 weeks, and at 9-month follow-up hadn't had any recurrence or complications. We have done this on a whole bunch of people and some preliminary safety data on 50 compartments with the median age of the people getting this procedure being 21.5 years old. The follow-up was an average of 19 weeks. We didn't have any complications. During the procedure, the average was a 3 out of 10. Within 24 hours after the procedure, The pain was up to a 5.5 out of 10. They took a median of 1.5 days off of school or work, and only about 10 days before they had resumed full unrestricted activity. So, from my standpoint, that's really successful so far. The pain prior to the procedure was an 8 out of 10. At the last follow-up, it was down to a 2 out of 10. Their global function, 10 being full function, 0 being no function. But before the procedure, they were 6 out of 10, and after the procedure, they were 9 out of 10. 75% of people were completely satisfied, and 100% said they would recommend it to others. So from my standpoint, minimal pain, rapid recovery, at this point, no complications. I'm sure there will be complications at some point, just if you repeat things, sometimes they don't go right. But that's pretty optimal. That's pretty optimistic at this point. So how do I do the procedure? Well, I map it out just like I did for the needle fenestration. But I start the procedure 3 centimeters distal to the tibial tubercle and end it 10 centimeters proximal to the inferior tip of the lateral malleolus for the anterior compartment, and 3 centimeters distal to the fibular head, and the same distal location for the lateral compartment. And I mark all of this with a marker on the surface and show where the meniscotome will be inserted. For the first study, I did 2 meniscotome sites, but now I do 1 single site. So this is what the meniscotome looks like. It's a 3 millimeter straight meniscotome with a V-shaped cutting tip. So you do a small incision. It's a 3 millimeter meniscotome, so you do a 3 millimeter incision. You put it through the skin, and then after having dissected the skin off of this cadaver, you can see how it bridges the fascia, and you just cut it almost like scissors and wrapping paper. So here you can see the meniscotome cutting the fascia. Same thing here, just in a short axis view. And here's a picture of the fascia afterwards. So here it's cut, and here it's together. So that shows that indeed, with the meniscotome, you are actually cutting the fascia. So our results showed that 100% of the time we were able to achieve our targeted length. And occasionally we had some intact bands, but they were very short in nature, and so very likely this would be a successful procedure based on the cadaveric study, and certainly our clinical studies have demonstrated that. So what are some pearls? Well, the first thing is use sterile technique. This is a surgical procedure. It takes about 30 minutes per compartment to perform, so it takes some time. I use 22 gauge 3.5 inch spinal needle for anesthesia, and I'm typically using a mixture of lidocaine with epi, regular lidocaine, and ropivacaine. And the epi reduces bleeding, but it also prolongs the duration of the local anesthetic. I'll often give people 1 or 2 hydrocodone 5 milligram tablets before the procedure to try to reduce any procedural pain. And I do a single incision site for the entire compartment. Afterwards, I will compress the area and have them ice and elevate. And if they feel like they're sore, I'll certainly give them crutches, but most people are able to ambulate immediately after the procedure. I have them follow up after a week. If they're doing well, then I have them progress as tolerated. So in summary, ultrasound-guided fasciotomies have 1 cadaveric proof of concept study, which was very positive, 1 case report, and then I have preliminary safety and efficacy data on the 50 compartments. So I'd say that while the evidence is level 3, it certainly is looking very optimistic in terms of the outcomes and the minimal risk of complications, but it does require further studies, and frankly it would be really nice to do some head-to-head research so that you can demonstrate the cost effectiveness of this procedure and the patient satisfaction. So I'm going to talk about just a couple of new procedures that I haven't presented on before in conferences. One's an adductor release and the other is an IT band release. So with an adductor release, people will typically have this done surgically by being placed in a figure 4 position. They'll do a 2 centimeter long incision, and then they'll release the adductor longus origin with the scalpel. But it takes 12 weeks to resume full and restricted activity. So the question is there a better way to do this procedure? So we decided to do a similar feasibility study in unembalmed cadavers, so 10 lower extremities. And I did ultrasound-guided releases in all 10 of these cadavers. I used the GO percutaneous cutting wire or cutting thread to perform the procedures. And we looked at a bunch of different metrics to grade how successful the procedure was. So to start with, I would use an 18 gauge 2.5 inch TUI needle to guide the, and I would guide that underneath the proximal adductor longus tendon. Then I would thread the cutting thread through it, and then pull the needle out, leaving the cutting thread in place. Would then loop the cutting thread around the top part of the adductor longus tendon using the same technique with the TUI needle. And then when I had the tendon looped, I would insert the ends of the cutting thread into the syringes using those as handles, and then I would pull those back and forth in order to saw through the adductor origin. And this is what it looks like on this video on the right side of the screen when I'm cutting through that adductor origin right there. And this is what it looks like after the procedure when you dissect out the area. So the procedure took on average about 4.25 minutes. And we were able to cut the adductor tendon 100% of the specimens. The cut location on average was 3.5 centimeters distal from the pubic tubercle on the adductor origin. No skin was cut in any specimen, and the tendon was completely cut in 80% of the specimens, with 2 specimens having a few little fibers remaining in the muscle. And essentially it was because there were some interdigitations of the actual tendon within the muscle. So we minimized the amount of muscle that we cut, but we didn't get the entire tendon. There was no muscle damage in 50% of the specimens. Less than 10% of the muscle was damaged in 40% of the specimens. And between 10 and 30% of the muscle was damaged in 10% of the specimens. So it was a very small number of specimens that had muscle damage or a very small amount of muscle damage with these, but that can lead to some bleeding. There was no adjacent structural injury, so no neurovascular structures were injured in the male subjects. There was not any inadvertent looping of the vas deferens or anything, so the spermatic cord, so everything was good from that standpoint. And I rated the difficulty about a 2.5, so 1 being no difficulty, 10 being extreme difficulty. So again, similar to what we did with the fasciotomies, we translated this into human subjects. So we had a 47-year-old male marathon runner who had prolonged history of left groin pain, was diagnosed with chronic left adductor tendinopathy and a labral tear. They had an arthroscopic repair of the labral tear and rehabilitation and a corticosteroid injection for their adductor longus tendinopathy. And unfortunately, while the hip pain got better, the adductor longus tendinopathic pain did not. So based on that and the fact that his activities were limited, he wanted to have an ultrasound-guided adductor release using the cutting thread. So prior to the procedure, he had a hip outcome score of 82 out of 100. In 3 months post-procedure, it had gone up to a 99. He reported a pain of 4 out of 10 during the procedure. He took 2 hydrocodone afterwards, just one time, and then 600 milligrams of ibuprofen twice daily for 3 days. There were no complications. He was able to return to unrestricted activity after 2 weeks and had what he would consider full recovery, so essentially no pain at that point after 3 weeks. So his pre-procedure pain was 7, his 3-month post-procedure pain with activity was 1, at 6 months it was 0. His global function went from a 4 out of 10 up to a 10 out of 10 over that 6-month time frame, and he was completely satisfied. So again, relatively simple procedure. It doesn't take long at all to complete, and it's able to consistently cut the tendon. There might be some bleeding though because of the cutting of the adjacent muscle, but at least in the athlete that we did the initial procedure on, he did very well, and there really wasn't any significant bleeding in the area. So, and it seems to be safe with no adjacent structural injury. So I think that this looks promising, but we just have to be aware it's a single case report, and we're going to have to do larger studies to see how this works in a larger cohort. So the next procedure I'd like to talk about is iliotibial band releases. And so this affects up to 12% of runners and 24% of cyclists, and it's due to compression and friction of the IT band over the lateral femoral condyle during knee flexion and extension activities. It will get inflamed, you'll get some degenerative tissue in that area, you'll sometimes get a bursopathy in that area, and it can also irritate the lateral synovial recess of the knee joint. So the typical surgery, if somebody requires it, is either an IT band longitudinal incision and bursectomy. They can do an arthroscopic lateral synovial recess resection and then debride the deep aspect of the IT band. Or you can do endoscopic or open IT band release, lengthening, and bursectomy. So the question is there a better way of doing this? So I did a similar study where I took 5 unembalmed cadavers, which are 10 lower extremities, and I did ultrasound-guided iliotibial band releases using that same wire and measuring the same outcome measures that I previously described. And I found when we did this, I would lay the cadaver on its side so that the lateral aspect was facing the ceiling. The knee would be slightly flexed, and I would identify everything prior to the procedure so I could do a proper pre-procedure plan. And I would identify the place that the most likely friction would be occurring, which is over the most prominent aspect of lateral femoral condyle. And I would mark that area and determine where the posterior margin relative to that was of the IT band. And then I would, the goal of this was to target an area that was 15 millimeters from anterior to posterior for the procedure, where I would want to cut. I used an 18-gauge TUI needle to guide the thread underneath and then above the IT band. You can see here the cutting wire was threaded through the needle that was underneath the IT band, and then I would guide the needle back over the IT band and thread back through the needle to loop the IT band. So then I would put on 2 syringes and do the exact same thing using those as handles and sawing through the IT band. So here's a video of cutting through that posterior 15 millimeters of the IT band. Here's a cadaveric dissection showing the IT band where it was cut. It took me about 4.5 minutes to perform the procedure. 100% of the specimens had IT bands that was cut, and the average length was 15.8 millimeters with a range of 15 to 17 millimeters. So pretty much right on what I was shooting for. There was no skin that was cut in the specimens, no adjacent structural injuries, and I rated it at 2 out of 10 in terms of difficulty. So again, relatively simple procedure. It didn't take any time at all to complete, and I was able to consistently cut to the desired length of the IT band and didn't cut anything else around it. So in conclusion, ultrasound can be used for a broad range of purposes in sports medicine. You can use it for diagnostic and prognostic purposes, but for this particular presentation, I talked about the guided therapeutic interventions and the ultrasound-guided surgical procedures. So ultrasound-guided procedures have evolved from these first to third generation procedures, with the third generation procedures being ultrasound-guided surgical procedures. We've been looking at those and developing the procedures in cadaveric models and then translating them into clinical practice. So I think these really have the potential to reduce healthcare costs, decrease complications, lead to quicker recovery times and increased patient satisfaction. But ultimately what these do and what we're striving for is enhancing our ability to care for our patients. So I'm really excited about this. I think there's a great future for ultrasound-guided surgical procedures, and I look forward to your questions. Thank you very much for your attention. Here are some of my references.